Hi, welcome to Optimum TV. I'm Stephen Adams. Today I'm joined by Thomas Kledal, CEO Synklino, a Denmark-based biotech which is developing a new treatment for CMV, a virus which can seriously affect people receiving kidney transplants. So, hi Thomas, good to have you here.
Hi Stephen, nice to be here.
So, Synklino has just treated its first patient in a phase 1 clinical trial of its anti-CMV treatment, SYN-002. So congratulations. Let's talk a little bit about CMV. What exactly is it? How common is it? And why does it pose such a threat to people who receive kidney transplant?
Yeah, thank you so much, Stephen. So CMV is a major challenge in transplantation, and it remains the biggest infectious problem in solid organ transplantation. So each year there are approximately 170,000 transplants worldwide, and of those, 70% will receive an organ that actually carries Cytomegalovirus, or CMV in short, posing a significant risk for a poor transplant outcome in these patients, including in kidney transplant. And it can lead to delayed graft function. It can lead to poor organ durability, organ rejection. And despite standard of care prophylaxis, it's still a high risk. So still 30 to 40% of patients that receive an infected organ and receive standard of care prophylaxis, they will actually develop an active infection associated with significant risks, including diseases, morbidity, mortality, rehospitalization, significant increased cost in transplant, and of course, a poor transplant outcome.
Okay, so CMV is endemic in the population. It's very difficult. You couldn't say let's target organs which don't have CMV.
It is everywhere, and in some geographies, it's more like 90 to 100% of the population actually have the virus. It's a herpes virus, so once you get it, you have it for life.
Okay, so you alluded to it just in answer to my first question, but if we're thinking about CMV in kidney transplant recipients, how are they currently treated, or how does the system currently deal with CMV, I suppose, more generally?
Yeah, so if you receive an infected organ, you will always know that. It's always screened for, and you will immediately start antiviral prophylaxis. All current therapies, they are given to the patient after transplantation, really trying to target the virus once it has reactivated from latency. And again, despite that antiviral prophylaxis, which you have to take for 3, 6, 12 months while you are immuno-compromised, you still see 30 to 40% of the patients that receive these infected organs, they will have a reactivation. So there is still a significant unmet medical need in this space where you can improve the outcome. And furthermore, the most prevalently used, frequently used therapies, they are associated with side effects, kidney toxicity, leukopenia, and so forth, which is really problematic to deal with after transplantation, especially if you receive a new kidney and you then need to take a drug that's toxic to the kidney. And then I think what is also important is that all standard of care, they can only target the virus once it has already reactivated. None of them can target the latent reservoir. They simply don't see it. So that is simply not possible with any standard of care opportunity.
Okay, well, I'm sure that leads us on to SYN-002 and how it works and how it's different from current treatment. So talk us through SYN-002.
Yeah, thank you. So SYN-002 is a fundamentally different approach, and we define it as a new therapeutic category, really, because we are not treating the patient with SYN-002 after transplantation. We are actually treating the organ before transplantation, making this fundamentally different from any available therapy. So with SYN-002, we target the the infected cells in the organs. We target both the cells that carry the active infection, but also the cells that carry the latent reservoir, really providing a means to get rid of the root cause of the problem before transplantation. And we do so by targeting a virus-encoded membrane receptor that's positioned specifically on the surface of all the infected cell reservoirs. So that really gives us a unique opportunity to get to the root cause of the problem.
Okay, great. So your news, you just treated your first patient in this phase 1 trial. So congratulations on this milestone. What are you looking to find out with this trial? Where is it taking place and who's involved? And what data can we expect, and when might we expect that data?
Yeah, so the phase 1 study is for good reasons, the key and primary endpoint is safety.
Sure.
It is a dose escalation study where we simply just increase doses and getting into the efficacious range pretty quickly. So primary endpoint is safety, but we are treating organs that are infected and we are transplanting them. So it also gives us a unique opportunity to actually look at an efficacy signal in a very early clinical study. We're also going to assure that we are not exposing the transplant recipients. They are quite vulnerable patients, so we are actually not exposing the patients, and we are going to confirm that in the study, but we are just treating the organ. So I think these are some of the key readout and parameters that we have included in the study. The study is an investigator-sponsored study, so it's taking place at the Atmera Transplant Center at the University Health Network in Toronto, and it's led by infectious transplant professor Dr. Atul Humar, who is really a world-leading capacity in the space, also involved in writing the therapeutic guidelines internationally for how to deal with CMV in transplant. We expect the safety readout to come sort of on a rolling basis during 26 as we escalate dose, and efficacy signals will be available to us sort of later in 26 and into 27.
Okay, great. Now, you wouldn't have got to this stage without a lot of work already accomplished. What existing results do you have to indicate that the science behind SYN-002 might actually work in humans?
Yeah, so we are actually in a really, I think, unique situation because we have basically done the phase 1 study already, except we haven't transplanted the organs. So since we are treating organs before transplant, we have been able to work with donated organs that have failed some key parameter and could not be used for transplant. And with consent, we have had access through our collaborators to actually test SYN-002 at relevant concentrations, the same way as we are going to do it in the clinical study that we are now started. So we have treated numerous human organs, kidneys and lungs. We have studied very thoroughly, of course, if there could be any signs of tox signal in these organs, and we haven't seen anything on any of the parameters that we have looked for during therapy. And at the same time, we can see that with just a 4-hour therapy, we can reduce the latent reservoir of CMV in these organs with more than 90%, which is not only a highly significant result, but also very meaningful because it is the number of latently infected cells that directly dictates the risk of reactivation and all these morbidities after transplantation. So we are really pleased to have this opportunity. And I should say here that the way we are giving the molecule is that we provide SYN-002 while the organ is positioned in perfusion machines before they are transplanted, simply adding the molecule to the perfusion that already takes place. So we can sort of tap into the existing infrastructure at transplant centers.
So there doesn't have to be a change in the procedure at all. It just feeds into what's already there.
Exactly. We are building on that expertise already happening at transplant centers and centralized facilities, yes.
Okay, great. Well, I'm going to ask you about what Synklino is doing in the next year or two. Obviously, your primary focus, I guess, is the trial, but I'm sure there's other things going on as well.
Yeah, I mean, we are extremely focused on moving SynW2 forward in development. And we are really looking forward to get the data out of the clinical study here on safety and early efficacy signals. So this is our primary focus, obviously. But we are also focused on how we can bring it further into later stage development, and expect to initiate a phase 2 trial in 27 as sort of the next major development inflection that we are moving forward to. I also think we are really trying to see how we can position ourselves in this ecosystem, in this transplant ecosystem, which is really developing dramatically these years, with several players providing new machines for perfusion and new opportunities, how to actually make more organs available for transplantation, make the process around transplantation better and smoother at transplant centers and so forth. So we are really looking into, could there be potential partnerships that could sort of help our positioning in this space? And I think that's activities we will also initiate in the coming years.
Fantastic. Thomas Kledal, CEO of Synklino. Thanks very much indeed.
Thank you so much for having me. Thanks.
Bye-bye.